have Dr. Carl Dogaramji with us, and therefore I want to take advantage of every minute I have with you. Sleep, as we know, is a tremendous challenge for us in psychiatry and primary care. And we are learning, aren't we, that GABAergic interventions, while very useful, there are some challenges with that. So, do this for me. Would you tell us a little bit more about how we clinicians should think about interventions that are either here or are coming from a mechanistic receptor profile?
This is a very critical question, because we're beginning to understand that the mechanism of depression is not uniform across depressive states. So, for example, we know that insomnia is a big feature of depression, but that insomnia might be mediated through melatonin receptor issues, serotonergic issues, and a number of other receptor profile abnormalities. So I think one of our first jobs as clinicians is to be able to identify the nature of the sleep disturbance, to be able to treat it more directly. So as an example, we know that a number of people with depression feature circadian or cycle abnormalities. Delayed sleep phase is one example, where people fall asleep late and wake up late. Now that sort of delayed sleep phase is eminently treatable with agents which we have available to us currently, such as, for example, melatonin. Melatonin given for a few hours before bedtime in conjunction with bright light therapy in the morning can gradually produce a phase advance or an earlier sleep-wake time in people who are either depressed or not depressed even, who have delayed sleep phase syndrome.
So you are advocating for the appropriate use of melatonin for that. But what if that doesn't work? What some options do I have? What should I be thinking mechanistically?
Mechanistically, in people like this, it may be a good idea to think more about the melatonin system.
Okay.
So, for example, agents that are being developed in this area, tazobactam is one of them. Not yet available, but an agent which may be soon available for the treatment of what we call non-24-hour sleep-wake syndrome. These are individuals who sometimes are blind, who develop a gradual phase delay, or a later and later and later their sleep-wake cycle begins to become later and later and later in the day, and they really have no control. They stumble, if you will, to a later and later time. And an agent such as that may be very useful for them.
What about non-pharmacological? What can I do from non-medication, behavioral standpoint?
So let's take light as an example. The timing of light could be so critical in when we wake up and when we go to sleep. When we wake up in the morning, exposure to bright artificial light or bright regular light is very helpful in terms of correcting our circadian rhythm. So, waking up at the same time every morning, exposure to light. And the converse is true as well. When we go to bed, there should be minimum light exposure. Interestingly, data have shown that light as bright as some of the PDAs could influence sleep in a negative way if people use them close to bedtime. So darkness for about an hour or two prior to bedtime, or as much darkness as possible. And bright light in the morning can be very helpful in terms of shifting things in the correct direction.
I got it. I really enjoyed this one-on-one consultation regarding a problem that I face all the time in my clinical practice. This is Rakesh Jain offering you a quick insight into sleep medicine from Dr. Dogaramji. Thank you very much.